Hello everyone. I'll continue my discussion about reproductive medicine, and today I'll be doing part 2. Well, it will be integrated approach. So in the continuation, now we talk about oogenesis and menstrual cycle. Well, when we talk about oogenesis, definitely it means development of the ova. And this process is known as oogenesis. Now, one thing very important and very interesting also. Primary oocyte begin meiosis 1 during fetal life. In the fetal life itself, that meiosis 1 occurs. And this completion of meiosis 1 occurs just prior to ovulation. Well, if you look into these two lines, this is fetal life. That means intrauterine life, when the baby child is not born. It is still in the mother's uterus. And we also know that ovulation occurs when the menstruation occurs. That is when menarche occurs. And once menarche occurs, then only the ovulation occurs. That means from this intrauterine life to the first menarche, up to that stage, this primary oocyte remain in the meiosis 1, and it completes just prior to ovulation. Okay, ovulation. Now, meiosis 1 is rested in prophase 1 for years. Point to be noted. It rested in the prophase 1 for about 12, 13, 14 years till the girl, that baby fetus is born as a baby child, female, and she start having menarche at the age of 13 years. Till that time, it is remaining the prophase 1, and this is so-called primary oocyte. Okay. Now, meiosis 2 is arrested in metaphase 2 until fertilization occurs. This is so-called secondary oocyte. If fertilization does not occur within a day, this is very, very important, the secondary oocyte will degenerate. Now, that is the point of a practical point, that there are many couples who are not getting, they are so-called infertile, they are not getting the child. That means the time of coitus is important. If it is not occurring to the time of ovulation, then definitely fertilization will not happen. This again basic concept which I discussed in the previous lecture, but again I like to refresh, and there is a special reason for that. We know that we have a homologous chromosome. There are 23 pairs of, and ultimately 2 and 2C. Then ultimately each chromosomes make 2 sister chromatid, and now it becomes 2 and 4C. 4C means the number of chromatid have gone to double. Now each chromatid makes one germ cell. So that's why we get 4 germ cell, which half of the chromosome. This is true for both male and female, but there's one difference is there. What is that difference? The difference is like this. Again, a bit of revision. We have a chromosome, and now this is a chromosome, and we have a 2 chromatids. There are 2 chromatids, right? And now the reason why I'm showing you this thing. In male gametogenesis, we started with 2 chromosomes, and we make 4 sperms. Okay, 2 chromosomes, 4 sperms. Here also we have a 2 chromosomes, but they also make 4 so-called final stage, but 3 degenerate. Only 1 ovum is produced. What is the carry home message? In males, 1 cell will produce 4 chromosomes, and in female only 1 ovum is produced, rest 3 which was supposed to develop, they get degenerated. The end result is 1 ovum only. Okay, so the same story shown in a different way. 46 chromosomes in a female, okay, single chromosome, and they make sister chromatids. Each one make a sister chromatid. Ultimately, what happen? They make one ovum, and the rest three, they are known as polar bodies. They degenerate. So in the most simplified way of presentation to these three slides, that in case of female, one ovum is produced. In males, there are 4 sperms are produced. That is the what I want to convey the message to you is. Of course, we all know that there are 23 chromosome and in ova 23 and sperm 23 chromosome when they combine zygote and they make 23 pairs or so-called 46 chromosome are made. When the fertilization occur, again it become diploid. They were haploid, ova is haploid, sperm is haploid, this is diploid. Diploid means 23 pairs of chromosome are made. Okay, so we learned about simple, only carry home message is one ovum but 4 sperms. Now we ovulation. Increase in estrogen, increase GnRH receptor on the anterior pituitary. This comes from hypothalamus. That we know very well. Okay. Now, increased estrogen occurs. There is increased receptor on anterior pituitary. Estrogen surge then stimulate LH release from the pituitary, anterior pituitary. LH release lead to ovulation, rupture of the follicle. When we say what is the meaning of ovulation? Ovulation means rupture of the follicle. And there is increased temperature, so-called progesterone induced. Point to be noted. Then when the ovulation occurs, when the ovum is released, and that causes increased temperature. But that is the progesterone effect induces there. This is a very important point that you got to remember. Now, menstrual cycle. We have a follicular phase. We have a luteal phase. And follicular phase may vary. Luteal phase is 14 days. Ovulation day plus 14 days is menstruation. Point to be noted. Okay. Follicular growth is fastest during the 2nd week of follicular phase. Estrogen stimulate endometrial proliferation. So we first talk about this. Let's go back to the diagram, without which you will not understand. This is the summary of the whole physiology, anatomy and histology. Let's talk about. Let's say, let's first talk about this anatomy. This the menstruation is occurring. Definitely, when menstruation is occurring, that means the lining of the uterus is shed out. And after that, it starts growing, we call as proliferative phase. This lining grows, proliferative phase. Then here is the ovulation is occurring. Then we have a secretory phase, and again the menstruation start. So we have a proliferative phase, we have a secretory phase, and we have a ovulation. Ovulation is going on. And remember that during menstruation, this shed down, the thickness of the endometrium is reduced because all things have come out. And again, it is the proliferation start and secretory phase. Simple histology. Now let us see what happened to the hormones. This estrogen start growing with a secretory phase. You can see this during the time of ovulation. Estrogen is almost in the peak stage, and after that it level falls. Progesterone level, it rises after ovulation, point to be noted. So it is the one, and of course if the fertilization doesn't occur, the level will go down. That means during the time of menstruation, estrogen and progesterone level are reduced drastically. So what we have to remember in this particular slide, estrogen, write down, estrogen is peak near the time of ovulation. Progesterone is peak after ovulation. It has a special meaning. The point to be noted, I can even simplify that the estrogen level will be high before the ovulation and the progesterone level are higher after the ovulation. Most simplified presentation of this. Now let's look into other hormone. Well, I talked to you regarding follicular phase and luteal phase. I also talked to you regarding proliferative and secretory phase. This is the where students get confused. Friends, let me clarify these terms. When we say proliferative phase and secretory phase, this is in relation to the endometrial growth. So now if I have to make your subject very simple, proliferative means endometrial growth before the ovulation. Secretory phase is what happened to endometrial after ovulation is there. So this is pre-ovulation, this is post-ovulation, endometrial lining. Now when we talk about luteal phase and follicular phase, again the follicular phase is before ovulation and this is after. But this is in relation to physiology. Let us see what happened. So this is the FSH. Okay, by and large stable is there. Now look into LH level is slightly less than FSH normally, but during the ovulation it is increased. This is so-called LH surge, and after that again LH level come down. So point to be remember, normal LH is always less than FSH. LH is less than FSH, but at a time of ovulation this become more, so-called LH surge, which is the reason why ovulation occurs. Now we look into the what happened to these follicles. Okay, so this is the developing follicle which contain ova, and now look into this follicle. Now this has ruptured and this ovum has been released. Point to be noted, in the previous slide I told you what is ovulation. Rupture of the follicle, it is shown follicle has ruptured, the ova has gone out and will be taken by the ampulla of the fimbrium and fallopian tube. Ultimately it will come to the uterus. If it get fertilized within 24 hours, okay, otherwise it will all degenerate. So now this follicle has ruptured. Remnant is corpus luteum, and it is this corpus luteum which produces progesterone. Point to be noted, it is this corpus luteum which produces progesterone. Okay, progesterone is getting produced by corpus luteum. If fertilization occurs, the corpus luteum will persist, otherwise it will also get degenerate and it will make corpus albicans, the remnant of the corpus luteum. So we learned about LH, FSH, we learned about follicle, ovum, we learned about estrogen, progesterone, and we learned about growth of the endometrial lining, and now we are clear about it. Follicular phase, luteal phase are different, and proliferative and secretory phase that are in relation. So I can make it simple that during the proliferative phase we have a follicular phase is proliferative, and when we say luteal phase is so-called secretory phase. Okay, coincide with each other. LH surge is for ovulation. With this background, now we talk about physiology of reproductive hormones. Okay, little bit of revision which I did in the previous slide also, previous lecture also. So we have a hypothalamus, we have GnRH, and that comes to the anterior pituitary which secrete LH, FSH. The point I mentioned in the previous slide also. Okay, so in females, we learned about males in the previous lecture but now I like to focus on the female part. So we have a LH, FSH, and we know that ovaries secrete testosterone, and this is converted into estradiol via aromatization. Point to be noted, it is the aromatase which converts testosterone into estradiol. Point to be noted, even the female, the testosterone is getting produced and which is getting converted into estradiol, and this is converted into estrone and this is converted into estriol. So they are the three female hormone: estradiol, estrone and estriol. About this I will talking to you in the coming slides. Okay, so we learned about three hormones. Now estrogen. Source ovary. Ovary is 17 beta estradiol. Remember, it is coming from ovary, but it is the testosterone which will get converted into estradiol. Placenta estriol, adipose tissue estrone via aromatization. Potency estradiol, that means this one is the most potent. Estrone, this one is second most, and estriol is the third most. So as far potency is concerned, this is rank 1, rank 2, rank 3. So this is the gold medalist as per Olympics, this is the bronze medalist, and this is the silver medalist. Well, things are easy to understand. Now function of estrone, the development of genitalia and breast. Point to be noted, when the ovaries are there, they are the ones which are going to produce genitalia and breast. So due to any reason, if ovaries have been removed, it may be in the early stage, 20, 30 years, due to whatever reason it may be, and that will lead to poor development of genitalia and the breast. Okay, female fat distribution, typically what we see is like this. Okay, this is again due to estrogen. It causes growth of follicle. We have seen in the follicular phase, estrogen is there which causes growth of follicle as well as endometrial proliferation. Again, go back to the slide, look into this slide, lovely slide. We learn that this all development occur due to estrogen. Similarly, the follicular growth, which all these occur due to estrogen. So remember, estrogen is involved in the follicular phase and the proliferative phase. Now, it also upregulation of LH progesterone receptor is all regulated by estrogen. Inhibition of FSH, LH, then LH surge. Remember, it always keep FSH, LH under control. But LH surge occurs during the time of ovulation, again induced by estrogen. Just recall my statement that estrogen occurs peak just before the ovulation, and ovulation occurs due to LH. LH is usually less than FSH, but at the time of ovulation, LH surge occur, and that lead to ovulation. Stimulation of prolactin secretion is again done by the estrogen at the time of of after delivery or during the time of lactation. Of course, prolactin play a role that I'll discuss very soon. Now, estrogen causes increased transport protein sex hormone binding globulin. It's increased by the estrogen. Increase HDL and reduce LDL. Again, a very, very important point. So, in the reproductive period of the female between 15 to 45, something like that, because of estrogen, HDL level is high and LDL level is reduced. Due to this reason, coronary artery disease is much less in female. But after the menopause, when the estrogen level is reduced, then there is reduced HDL, increased LDL. And that's why coronary artery disease increases after menopause. In fact, between the age of 15 to 45 or 50 years, CAD is 4:1 ratio, male-female. But after 50 years, it almost become equal. It's all because of estrogenic effect that coronary artery disease is much less in females. Now we talk about pregnancy. 50-fold increase in estradiol and estrogen. 1,000-fold increase in estriol. Oh, all the three are increased. Estrogen receptor expressed in cytoplasm, translocate to nucleus and when bound to estrogen. So we have estrogen, okay, they are in the cytoplasm. They go to the nucleus where they are bound by the estrogen. So estrogen is bound to the nuclear receptor. But one thing is very clear, in pregnancy, all the three types or forms of estrogen, they are increased, and maximum increase is estriol. Okay. Let's read little bit biochemistry aspect of what happened. We have a follicle. In the follicle, we have a theca cell and we have a granulosa cell. Let's see the bigger picture. This is a bigger picture of so-called theca cell. This is theca cell. Cholesterol is there. It enters the theca cell and that converted into endostenedione by desmolase. LH get attached to receptor and it makes CMP, and CMP is needed. Cyclic AMP is needed to convert cholesterol into endostenedione. So if I have to give summary of what happened in the theca cell, cholesterol get converted into endostenedione by desmolase, but cyclic AMP is needed. This is generated by LH. This is bound to LH. R is LH receptor. So this is a granulosa cell. We have a LH receptor. LH comes and that creates cyclic AMP. And this cyclic AMP, cholesterol will enter, will convert cholesterol into endostenedione. Then we have a granulosa cell. Now this endostenedione will enter into granulosa cell. Now this is converted into esterone via aromatase. Again we need cyclic AMP, but now we need FSH. This will again produce cyclic AMP, and this endostenedione will convert it into estrone, and this estrone is converted into estradiol, but again we need aromatase to convert endostenedione. Point to be noted that we need LH for the production of endostenedione, but we need FSH to get converted endostenedione into estrone. So finally, what we learned that estrogen is getting produced from the male androgen getting converted into female estrogen. Now we talk about progesterone, source corpus luteum. If it gets fertilized, corpus luteum will keep on producing progesterone, otherwise it will go degenerate and make what? corpus albicans, placenta, adrenal cortex, testes. They are the source of progesterone. Now, normal source. Of course, placenta is the most important source in pregnancy. After delivery, progesterone level falls because placenta is not there, which is the main source of progesterone. Delivery has occurred, placenta has come out, the source of progesterone goes away, and now this causes prolactin, lactation secretion. So that means progesterone had a inhibitory effect on the prolactin, and now prolactin will be there and lactation will be there. Increased progesterone is indicated of ovulation in the normal, remember the normal cycle, normal menstrual cycle. Progesterone level has increased and remain increase, point to be noted. Normal progesterone, again go back to basic. This is the LH surge, and then this is the estrogen. This is the progesterone level. This is the ovulation, and before ovulation estrogen increases and after progesterone increases. If pregnancy occurs, the will remain like this. But pregnancy does not occur, progesterone level will fall. So if the level remain high, maybe after 4, 5, 6, 7 days of ovulation, progesterone level high, perhaps pregnancy has occurred. So progesterone is progestation, prolactin is prolactation, the mnemonic to remember. Now, what are the functions of progesterone? During the luteal phase, that is after ovulation, it prepares uterus for implantation of fertilized egg. I told you, if the egg gets fertilized, the progesterone level will remain high. It will prepare uterus for the implantation of fertilized egg. So, stimulation of endometrial glandular secretion and spiral artery development. Oh, remember the secretory phase. Secretory phase, what happened? Endometrial glandular secretion and spiral artery development. Okay, so it also produces thick cervical mucus, so that even more sperms come, they will not be able to enter. Progesterone is a security guard. He allows only one person, VIP has come, fertilization done. Now we don't need more sperms. Well, sperms can come anytime. Sorry, no entry. One job, one ova need only one sperm. Fertilization has occurred. That vacancy has been filled. No more. Millions of sperms come. Sorry, no entry. Why? Progesterone makes cervical mucus very thick. They cannot penetrate, or door is closed. I hope you understood. Now, prevention of endometrial hyperplasia. It keeps that, not that endometrium is multiplying. No, it limits. That is again controlled by progesterone. Increased body temperature, that I told you. Decrease estrogen receptor expression. Now decrease LH FSH. Point to be noted. Now the main role after fertilization of progesterone is the main that we have to be, which is preparing the uterus for implantation. Progesterone is making the mucus thick. All is done by progesterone. So now pregnancy has occurred. It will maintain the pregnancy. It reduces myometrial excitability. Very, very important. Because if myometrial excitability will happen, myometrium will contract and the fetus will come out. That will lead to abortion. Again, it maintains the pregnancy. It prevents the abortion also. So it decreases contraction and frequency, intensity of myometrial contraction, and decrease prolactin action on breast. That means as long as progesterone is there, they also cause reduced prolactin, the milk will not be produced. Good. Now we talk about androgens. Testosterone, dihydrotestosterone and androstenedione. There are three androgens. There were three estrogen. Okay. Source DHT. DHT come from testes. Easy to remember. Mnemonic DHT from testes. But androstenedione is from adrenal. This from adrenal gland. Okay. So DHT and testosterone from testes. Androstenedione from adrenal gland. Potency DHT is more powerful than testosterone and androstenedione. Even potency varies between the three, the way we have a different potency in estrogen also. Function. Testosterone, they were the one with cause differentiation of epididymis, vas deferens, seminal vesicle, all internal genitalia except prostate. If you have seen my lecture number 1, there I have explained everything. If you have seen, fine. If not, go and see part 1. There I have explained all this very beautifully. Okay. Growth spurt, penis, seminal vesicle, sperms, muscle, RBC, all these are what happened. Genitalia enlarge during the puberty, all because of testosterone. Deepening of voice. We are all well aware that before puberty, even the male child has a voice like a female. But deepening of voice occur after testosterone. Can I give you a day-to-day example? Yes. You must have seen so many movies where maybe a male child of 7 years is singing a song. And you must have noticed that 7-year-old, 6-year-old child is singing a song. The playback singer will be a female. It will not be a male. But again, this boy of 7 years now has become 20 years. Now he is singing a song for his girlfriend. It's a male voice. But at the age of 7 years, female voice, because the deepening of voice occur after puberty. So now I think the best day-to-day example to know the deepening of voice, the meaning. Closing of epiphyseal plate, because estrogen get converted from testosterone, so that lead to closing of epiphyseal plate. Libido, of course, testosterone is needed to have a libido. DHT, early differentiation of penis, scrotum and prostate. Later on, prostate growth, balding, sebaceous gland activity. All these in the elderly person, male pattern baldness. Well, maybe in the initial stage, the patient, because the young man have a beautiful hair, he makes a lovely puff. But same person after age of 50, 55, a total clean chit. He become, total male pattern baldness occur, all courtesy DHT. Now, little bit of biochemistry. Testosterone is converted to DHT by 5-alpha reductase. This I have told you the biochemistry aspect in the lecture 1. This is inhibited by finasteride. So this will not convert into DHT. In male, androgen are converted to estrogen by cytochrome aromatase. Primary in adipose tissue and testes, I mentioned in the previous slides also. That is it is the androgen which are converted into estrogen by aromatase. Aromatase is the key enzyme of conversion of androgen to estrogen. This I showed you in the previous slide, which you must have written by now. So now we learned about various aspects of hormone. Let's let our physiology of pregnancy. Pregnancy, fertilization occurs most commonly in upper end of fallopian tube. If I have to show you a picture, okay, this is a fallopian tube, this is the ampulla, and this is the ovary. From ovum comes ovum comes here, and sperms, yeah, sperms goes all the way. Just see, the lady ovum, she is a VIP person. Sperm travel all the way up to receive her highness. Okay, and this fertilization occurs here. It occurs within 1 day of ovulation. It has to be, rather I should say, if it doesn't occur 1 day, within 1 day, this ova will get degenerate. So that is a very many couples, those who do not conceive, they have no idea of this menstrual cycle. And that's why, despite everything okay, if they are not getting conceived, perhaps they are not doing the coitus in the right time. Now, implantation occurs within the wall of uterus. Well, this zygote has formed, and this zygote will travel down and they get implanted here in the uterus. It occurs 6 days after fertilization. That means it gets fertilized and it takes 6 days to come to here. So that means within 1 day, within 1 day it has to be fertilized, then 6 days needed to come to the implantation. Now, little bit of syncytotrophoblast. Basic embryology. It secretes HCG. But what is syncytotrophoblast? Yes, I'll be showing you the picture very soon. That it is the part of placenta. This is now this HCG which come from syncytotrophoblast, detectable in blood within a week after conception. Point to be noted. But in the urine, it is after 2 weeks. You typically in a clinical practice, if the urine testing is done, but this become positive after 2 weeks. But in the blood, it is become within 1 week. Gestational age is calculated from the date of last menstruation period. Point to be noted. Now, what are the physiological changes that occur in pregnancy? Renal, increased GFR. Glomerular filtration rate increases, decreased BUN and creatinine occurs. This is due to hemodilution. Decreased glycosuria threshold. That's why glucose can appear in the urine. So-called glucose can be there in pregnancy in the urine, but that is not an abnormal finding. It can happen. Increased cardiac output, increased preload, decreased afterload, increased cardiac output. Tachycardia is a feature, and increased placental and uterus perfusion. Definitely, it has to be there. Unless uterus will get perfused, placenta will not get perfused, then the baby will not get proper blood. Hematology, anemia. Although there is increased plasma, increased RBC. Now, plasma increase is much more. RBC increases this. So there is a relative hemodilution. So despite increase in RBC number, this anemia is there. Hypercoagulability is a feature of pregnancy. What is the idea? Idea of this is to decrease blood loss at delivery. So body has made a mechanism that when the placenta will get separated, there has to be a little bit of hypercoagulability so that natural stoppage of bleeding should occur. If not, patient will bleed to death. That's a natural mechanism to create hypercoagulability. But don't forget, this can also lead to deep vein thrombosis, which can lead to pulmonary embolism. This complication can occur. Hyperventilation is the feature, and that's again so that even CO2 produces mother's own and the child also. So extra CO2 getting produced from child by hyperventilation, the CO2 will go out. It's again a need because more and more CO2 getting produced. So hyperventilation is needed. That will throw out the CO2. Metabolic increased lipolysis and fat utilization. Why? Why? Because of maternal hypoglycemia and insulin resistance occur. So this is, of course, we are well aware that whenever insulin resistance occur, lipolysis occur. So this preserve glucose and amino acid for utilization by the fetus. More and more glucose is used by the fetus. Now look into the placental hormonal secretion. Generally increase over period of pregnancy, but HCG peak at 8 to 10 weeks. Look into this. This is worth $1 million slide. Look into this weeks of gestation. 7 week, 42 week. So if you look into the hormone, this is progesterone and this is human placental lactogen, this is prolactin, this is estrogen, all are increasing in due course of time. But HCG, it is peak in around early phase and come back. Point to be noted, near the term of pregnancy, all these hormones are increased. Exception is HG, which is peak in the early stage. Very, very important point. So now we talk about human chorionic gonadotropin. About this, source is syncytotrophoblast of placenta. Okay, what is this? I mentioned about this the previous slide also. Look into basic concept. So this is the uterine glands, uterine vessels. Fair enough. Uterine vessels. This is a placenta. In the placenta we have a syncytotrophoblast and cytotrophoblast. Syncytotrophoblast is the outer layer. It is this layer which is in continuation with uterus. So now you can see these uterine vessels are in touch with the blood vessel of the syncytotrophoblast. Okay, and there's a mesoderm from which they develop. So I dare to tell you that this is syncytotrophoblast which is in direct touch with the uterus. So now we come back. So HCG is getting produced by the syncytotrophoblast. Is a epithelial covering of the highly vascular embryonic placental villi which invade the wall of uterus to establish nutrient circulation between embryo and the mother. You can see it is like finger-like projections entering into the uterine wall, and that's how it makes a bridge between the placental and the fetal circulation. Function, it maintains the corpus luteum. Remember, thus progesterone for the first 8 to 10 weeks of pregnancy. First 8 to 10 weeks of pregnancy. After that, placenta makes its own estriol and progesterone and corpus luteum degenerates. Okay, corpus luteum degenerate, now not needed. And it is used to detect pregnancy because it appears early in urine. HCG we use to detect pregnancy. Now, it has a alpha subunit which is same as LH, FSH and TSH. And remember, it's a TSH state which may increase as HCG can induce hyperthyroidism little bit, not strong. But beta unit is unique. That is what we test in pregnancy. HCG increases in multiple gestation. Definitely more multiple pregnancies there. Okay, if they are twins or more than that, HCG level high. Hydatiniform mole, very, very important. Choriocarcinoma. They are the two important pathological, especially hereditary form mole, where HCG level is very high. Rather, it's a diagnostic investigation in H mole and choriocarcinoma. It is also increased in Down syndrome. HCG is decreased in ectopic or failing pregnancy. Very obviously, Edwards syndrome and Patau syndrome, it is reduced. In Down syndrome, it is increased. Now, human placental lactogen, also known as chorionic somatomemotropin, but usually they call as HPL. Again, from syncytial trophoblast of placenta, from where HCG also came. Overall increased insulin resistance is an anti-insulin effect. So this is one which is a diabetogenic. So you can say it is a diabetogenic It stimulates insulin. Oh, very interestingly, at one place it is insulin resistance. When insulin resistance will be there, body has to secrete more and more insulin in reciprocation. Okay. So gestational diabetes can occur if maternal pancreatic function cannot overcome the insulin resistance. Of course, that's what I told you. It will try to produce more insulin, but of course, resistance is very high. So, of course, pancreas has a limit. Beyond which it cannot secrete insulin. Okay, so that's why patient lady can develop diabetes. Finally, lactation. Little bit of lactation, basic physiology. From hypothalamus, we have a dopamine. From anterior pituitary, we have a prolactin. And this prolactin is under inhibitory control. This protein is under inhibitory control of prolactin. Or I can again day-to-day example. You park the car, yes, and quite possible when we park the car we use a handbrake. We use because it will not the car move. So you start the car, handbrake is on. Your car will not move because handbrake is there. This is like a handbrake. And now during after delivery, when the body need milk, this dopamine inhibition disappears. Now no handbrake, more and more prolactin will secrete it. This will come to the breast and it cause milk formation. Now one more thing, many students are not aware that this occur in males also. In males also prolactin is there, but they remain under inhibitory control of dopamine throughout the life. So that's why when we give any drug which is a dopamine antagonist or which remove dopamine, and the side effect of this drug is galactoria. Any drug which is a dopamine antagonist will lead to increased prolactin, and that will lead to milk formation. In the male, what we call as galactoria. Why galactoria will happen? Because prolactin is there and it is under inhibitory control of dopamine. Now you understood the basic mechanism why galactoria will occur in males. So I told you this under inhibitory control. So now even in pregnancy also. In pregnancy also, it is prolactin is under inhibition, but now progesterone is there. Progesterone, it again has a inhibitory effect on prolactin release. After delivery, the progesterone level goes down drastically. So this inhibition goes, and now even this inhibition from dopamine gone. Other break was from progesterone, both are gone, and that lead to lactation because of increased prolactin secretion. Suckling is required to maintain milk production. and ejection. So that's why when the newborn baby suckles the mother's nipple, that causes milk production. So it increases nerve stimulation, increases oxytocin and prolactin. So this suckling by the mother, by the fetus, increases oxytocin and prolactin, will cause more and more milk formation. And oxytocin assists in milk let down. It also promotes uterine contraction. Okay. So, and prolactin induces and maintains lactation, decreases the reproductive function, and that's the reason why so-called lactational amenorrhea occurs. Lactational amenorrhea, because reproductive function are reduced and the lady cannot conceive. Lactational amenorrhea is there, and oxytocin, which lead to uterine contraction. Breast milk is the ideal nutrient for below 6 months. Now a little bit of pediatric. Okay, it contains maternal immunoglobulin, especially IgA. This is some most important line from immunology point of view. Remember, IgA are in secretion, all secretion. One more word. If I ask you, write down the answer in your copy, which immunoglobulin is in maximum amount in the body? GAMDE. There are 5 important immunoglobulin: IgG, AMDE. My question is very specific. Write down the answer in your copy. Which type of immunoglobulin is in the maximum quantity in the body out of these 5? Well, G is the most common wrong answer. Answer is A. If they asked you maximum amount of immunoglobulin in the body is A, but maximum amount in the blood in the body is G, because this remain in the secretions, maybe tears, maybe saliva, maybe any secretion, but in the blood maximum is G, and overall A is the maximum. So it reduces infant infection, and it is also seen that those baby who take mother's milk, they have a less chance of asthma, allergy, diabetes, obesity, less chances. That means those who are top fat, they have more chances. And of course, no need to say that it decreases maternal risk of breast and ovarian cancer. That means even disease of fetus are reduced, disease of mother, important disease, breast and ovarian cancer are reduced. And of course, it facilitates mother and child bonding, is the source of breastfeeding. Well, finally we come to the menopause, diagnosed by amenorrhea for 12 months. Point to be noted, 12 months. Decreased estrogen production due to age, decline in number of ovarian follicles. That means estrogen level reduce. Key word is 12 months, decreased estrogen. Average onset 51 year, earlier in smoker. That's why you should always tell ladies not to smoke. Preceded by 4 to 5 years of abnormal menstrual cycle, any amenorrhea, any menopause, 3 to 4 years, they will have irregular cycles will be there, and finally about 50, 51. Of course, it's not 50. Of course, I've written 51 because it was given in majority of the literature, but it's never fixed. It can be 47, it can be 48. Variation is not, it's not a deadline. It will never happen before 51. No, it's not like that. Now, the source of estrogen after menopause become peripheral conversion of androgen in androgen. So that got converted into estrogen, and that's so androgen level will increase, and that's the reason why hirsutism occur post menopause. Increased FH is specific for menopause. This is due to loss of negative feedback on FSH due to decreased estrogen. So increase FSH occur, reduce estrogen occur, increase androgen occur. So androgen and FSH, they increase, estrogen get reduced in menopause. So increase GnRH, increase FSH, increase LH. Yeah, all together. GnRH is the one which is going to cause increased LH and FSH and decrease estrogen. Don't forget this. So don't forget, it's a very, very important slide to remember. In menopause, estrogen increases and GnRH, FSH, LH, and you can add androgen also increases. So all increase except estrogen. Features of menopause: the pneumonic is havoc, hot flashes. It's the one which really disturb. In fact, this is one reason why the lady always visits the gynecologist at the age of 40-45 years. Atrophy of vagina will be there, osteoporosis, coronary artery disease, and sleep disturbance. Regarding coronary artery disease, I told you after menopause, LDL increases, HDL reduces. But even osteoporosis, because decreased estrogen will lead to osteoporosis. Now I have a question for you. Write down the answer in your copy. Tell me any drug which we use in hematology. Tell me any drug, write down the answer in your copy, a drug which we use in hematology which is notorious to induce osteoporosis. Drug we use in hematology which induces osteoporosis. Write down the answer in your copy. Well, answer is heparin. So that's why heparin should never be used for more than 5 days at a stretch, because this can induce osteoporosis. Osteoporosis can be induced by low molecular weight heparin also, but less than the heparin. So now menopause before the 40 years. I mentioned in the slide that it is not that 51, it can occur at 45. But if it occurs before 40, then it is definitely something abnormal. This is so-called primary ovarian failure. It may occur in women who have received chemotherapy or radiation therapy. In these cases, ovary will fail. So 40 years or before is definitely abnormal. But 40 to 51, any time it can happen. Usually 41 to 51 is the time for menopause. Okay. Thank you very much. God bless all of you.